Okay, so good afternoon, all. Thank you for joining us on this very cold and rainy day today. So we're really delighted to have our second session, which is part of our three-part series on cancer education with Dr. Pawan Randev. So for those of you who don't know, my name is Dr. Adam Muller. So I'm a GP here in Leicester and one of the clinical leads at the LLR Training Hub. Really great to see so many of you join us today. Just a couple of housekeeping rules. If you could please just mute your microphones and switch off your camera when our speaker is talking, just to avoid kind of any unnecessary distractions. But of course, we want to make the sessions as interactive as possible. So please do put your questions in the chat and we'll have time to go through Q&A and a bit of a discussion as well. We will, of course, be recording the event as well. The recording will be sent automatically to those of you who registered. Otherwise, it will be uploaded to our online CPD calendar on our website. So without further ado, I will now hand over to Dr. Pawan Randev.
Thank you, Adam, and welcome to the second in this three-part series on cancer in primary care. My name's Pawan Randev. I'll just go into the slide set so that we can talk through it now. There's quite a lot to get through, but we're going to send you a PDF of all the slides, and hopefully they'll all be linked. So if you find any of the images, you can click on them and it'll take you through to the source document. Now I'm just going to put my very first slide up, and this is just reminding me what I look like and the date today. I do include my email address in all my presentations. I'm always happy for people to engage, and helpfully some of you did engage after the first of the webinars. So I'm just going to go on to the next slide. Can I check, Adam, has this come through as
Yes,
the
it
About
has.
Me page?
Moving
Fabulous.
perfectly. Yeah,
Lovely.
perfect.
Just a very brief summary. I've retired from clinical general practice, but continue to be passionate about cancer and work within the East Midlands Cancer Alliance as a cancer lead. I was one of the primary care leads in LLR for a fairly long period of time, and I've got lots of cancer stuff that I've done. Happy to pick that up with anyone who's interested in that. Number of projects on the right-hand side that I have been involved in. Moving on to what we're going to cover today. The first webinar 2 weeks ago was about what cancer means to primary care. This second one is a focus on cancer screening programs. And the reason for that is there are some changes and also some interesting elements of cancer screening that will be relevant for yourselves when you're looking after patients, but also in terms of whether you decide to undertake quality improvement activity, either as a GP for appraisal purposes or for general quality improvement, or if you are a GP trainer, these form excellent projects for QI for your trainees. Our third webinar is going to be about cancer diagnostic tests, and that will be in 2 weeks' time. So what we're going to cover today in session 2 is a quick reminder of, for those of us who are old enough to remember, there were the Wilson-Jungner criteria, which were a big thing when I was training, and it was all about why we screen and what the important elements of illnesses and screening programs. An overview of the current programs, a quick talk about prostate screening and where we are or not where we are at the moment. Then we're going to talk about the factors in reducing uptake and then looking at your own data, because at the end of the day, that's the stuff you want to know about. Finally, we're going to move into some quality improvement or audit type projects where we can look at the evidence-based approaches to improving uptake. And there is a small bonus about a project that I'm running at the moment in Derbyshire and hoping to expand, all about diabetes and cancer. And the final bonus is for those of us who happen to be over 50 or approaching 50, or have parents who are in their 50s and over, where I'm going to mention the importance of knowing your FITS number in the bowel screening test. So the Wilson-Jungner criteria go all the way back to 1968, but they are important principles. And some of them are really obvious. So the condition that you're screening for should be an important problem. But importantly, there should be a recognizable latent or early symptomatic stage. We must know how this condition develops. There should be an acceptable, suitable test that's there and tested already for the population before we roll out screening. We should agree on who is a patient in this context, as well as recognizing and having the resources for treatments for those patients who have disease that's recognized through screening. There must be an economic case, and the whole process should be continuing and not just a single one-off project. Now, the Wilson-Jungner criteria, long time ago, the National Screening Committee has actually updated them. And this is from 2022. And for those of you who perhaps want to go back into understanding screening, perhaps if you have trainees or you want to have that detail, this takes out and expands all of those criteria and adds a couple as well. So this is if you're on the nerdy end of things, but really want to have the classic, clear information about population screening. So what are the current screening programs? And we all know in general practice that there are three of them that are running: breast screening, which is one of the older programs, cervical screening, and there have been some changes in that, and also the newest program nationally is bowel screening. And I'm going to talk about all three of those in more detail. However, before we go on, let's talk about lung cancer screening, because this is coming to Leicestershire and Leicester City this next year, or within the year, we hope. And the reason for this is that smoking causes the majority of lung cancer cases. And we know that diagnosis at stage 1 through screening gives a 95% survival. And if you're diagnosed at stage 4, it's a fraction of that, at only 4% of 5-year survival. The lung screening program is aimed at men and women between the ages of 55 and 74 who are coded as ever smokers. And they are offered a low-dose CT scan at 2 yearly intervals. At the moment, this program is already running in many parts of England. And within the East Midlands, we were fortunate enough to have 2 pilot sites, one in Nottingham and one in Kettering. So actually those pilot sites over the last 3 or 4 years have been generating the data that's led the National Screening Committee to agree that lung cancer screening can be expanded as a national program. Now, when we look at the pilot data, actually just under 2 million people had been invited for the checks, picking up over 5,000 cancers, the majority of which were diagnosed at stages 1 or 2, which is amazing. And this is leading to a complete turnaround of lung cancer from being the cancer that kills the most and also has the poorest 5-year survival. It's gradually moving towards a much better prognosis. The other important thing to note is that of all the screening programs, this is the one that actually addresses the deprivation gradient. And so what they've found is that of the lung cancers diagnosed, more have been diagnosed in a deprived population than in a less deprived population. So from a health inequity point of view, this lung cancer screening program has become really important. Now, one of the challenges with lung cancer screening and doing the CT scan is the CT scan is a very detailed look at the lungs and including the heart. And as a result, there are often incidental findings, and they may range from coronary artery calcification through to sometimes actually detection of things like kidney tumours because of how low down the scan will go. And last year, there was a national agreement on how these were going to be managed. And the protocol that's been agreed nationally, but still to be finalised locally, actually sensibly puts the incidental findings into four categories, from life-threatening to non-significant, with standardised pathways. So this is something that will be coming to Leicester and Leicestershire later on this year. There will be a lot of communication, but I want you to be aware that this is something really good that's coming our way in the near future. Another thing that I think I'd better address, and which always comes up when we talk about screening, is what about prostate? Because every now and again, the Daily Telegraph in particular, but most media outlets will pick up on a bit of research or on a survey where PSA screening is recommended or a case is made. And currently, we have a consultation open, which closes next week, looking at PSA screening and whether that should be offered. In the box on the right, you can see that at the moment, the draft recommendation from the National Screening Committee is to offer targeted prostate screening to men who have confirmed BRCA. And this is a really important thing, something that not too many people are aware of within primary care. That if you're a man with BRCA genes, and those are the same genes that in women give rise to a higher risk for ovarian and breast cancer. But if you're a man that has those genes, you are at greater risk of prostate cancer. And so there's a particular recommendation, that first recommendation about a targeted program. They don't recommend population screening or targeted screening of Black men or targeted screening of men with a family history, which is surprising. And this is something where the consultation period is critical because they are going to get a lot of data and feedback about those groups. The other thing that they've said is that they're going to be looking at something called the Transform trial, which is looking at screening for Black men and men with a family history. So they're waiting for the data to appear. And also there's another trial called PROMIS, PROMIS, which is looking at using PSA plus MRI scanning and seeing if that will give a more accurate outcome than just the PSA alone. So this will lead to clear recommendations, which will come out later on this year. So please be prepared for some changes, but I suspect not dramatic changes within those draft recommendations. When we think about PSA testing and screening, I will come back to this issue in our next webinar, but I think it's reasonable for you to be aware of some guidance that was put out by Cancer Research UK in November of last year around PSA testing. And you may find this information, it's a two-sided A4 from Cancer Research UK, you may find it very helpful. And in particular, the what do your patients need to know? And for this, if you just click on either of those images, it should take you through to the relevant resource, which you can download onto your own computers. And it goes through, it's very sensibly done. And I know the people that have written it, they are working GPs and have taken lots of expert advice with the recommendation. Within the Cancer Alliance, we're producing a local version, which is coming out in the next 2 or 3 months for guidance for ourselves. And that will include a professionals as well as a patient-facing leaflet. So let's move on to screening itself. And I want to share with you some data. And here I'm going to contrast Leicestershire, the top box, with Leicester City, the lower box. And the top box is data that I've got from actually last week when it was released. And so we know in Leicestershire that when we look at the coverage of breast screening, cervical screening, and bowel screening, you're talking over 70%. And you're talking with bowel screening and cervical screening for the older age group over 75%. So really very high levels of take up. If you look at the bottom box in Leicester City, on average, we're getting much lower take up. And for breast, it's about 15, 16% lower. For cervical, it's lower, but interestingly, if you look at the difference between the younger age group, the 25 to 49, where it's 56, and the older age group, where it's nearer 70, much less of a difference. So there's something which is challenging with that younger age group. And I will talk about that and what we can do within practice. Looking at the bowel screening program, and in this, they are only looking at the 60 to 74 age group. And I will share with you that the lower cutoff for bowel screening this year is changing down to 50. So the data that you've got here applies to the older group within bowel screening, but there is some important information about that 50 to 60 age group that we'll come on to later on in the presentation. So if we start, first of all, with cervical screening and looking nationally and across regions, you can see that across England, if you look at that younger age group, the 25 to 49s, in England, it's 67.5%. In the Midlands, it's 67%. But what I would say is don't be fooled by the averages. Because if you think of our Leicestershire averages, what happens is that the Shire of Leicester brings up the average, and Leicester City actually has lower uptake. So you therefore need to be in a position to look at your own data, and you will have your own data through QOF and through looking on your System 1 reports. But there are publicly available resources that I will show you later on that let you compare your practice within your PCN and at ICB level as well. When you look at cervical screening and you look at the geography across England, what you can see is that on the left-hand side, that's the 25 to 49 group. And I'm afraid that little red dot right in the centre of England is Leicester City. So that reflects the lower uptake in the 25 to 49. The same red dot turns amber in the 50 to 64 group. So this is just another way of showing the difference between Leicestershire and Leicester City. And this is a little bit more of that same data that we've looked at for the older age group. And you can see nationally, there is a greater uptake in the 50 to 64s. And there are many reasons for this. So what's changing? Well, from last year, there was a big change. And we know that when cervical screening is performed, usually by our practice nurses, that the programme is testing for human papillomavirus, HPV. Now, because the test for HPV has improved, the screening committee has recommended that if you are a woman that's tested negative for HPV, actually, we can expand your screening time. So instead of being invited every 3 years, you can be invited every 5 years if you are negative. However, if you do have HPV, then you will be invited back every year, every 12 months until the HPV is cleared. So when we think about these women that don't take up screening, 2 years ago, we conducted a large survey. And as part of the survey, we asked women about cervical screening and what put them off and meant that they didn't attend the screening, or what they were particularly worried about. And what we found was that pain or fear of pain was actually one of the highest reasons why women didn't attend. So when we communicate with women, perhaps sharing the experience of women who haven't found it painful, uncomfortable perhaps, but not painful. Another large group is those women that have had a bad experience, whether it was pain or embarrassment or whatever. So there's something about addressing that and highlighting that actually we take great care. And if you have had a bad experience, do you want to come and talk about it? Now, this particular cancer awareness measure, that's what CAM stands for, actually contains stacks of information for us. And I'll go into this a little bit more in our next webinar when we talk about why people present at different stages. However, when you break down that data from the cancer awareness measure and you break it down into the white ethnicity and ethnic minority, so this is looking in particular in the city, you find that in fact the fear of pain is significantly higher in the ethnic minority group. And there was also a significant number that didn't attend because they felt they didn't have any symptoms. So there's something about highlighting that this is a test that looks for asymptomatic people and it doesn't look at people who have symptoms. There are different pathways and approaches to take for those people. So this information may be useful if you're starting to think about what can we do to improve cervical screening or to understand what the challenges are for women that are attending. When we think about cervical screening, there is a really good practice guide that Cancer Research UK put together last year with lots of information for our nursing staff. And also, if you are a GP trainer, you might want to share this with your trainee as part of a discussion either about a potential QI project, but also to understand the cervical screening programme. And it's helpful to remember that of every 100 people that are screened, the great majority, over 87, will be negative. And actually, only 12 will be positive and invited for screening. And of those positive patients, only 4 will actually require further investigation with colposcopy. But one of the reasons why cervical screening and HPV, which we've mentioned a few minutes ago, is so important is that we all know that there's an HPV immunization program for boys and girls that's been running for several years, leading a couple of years ago to this headline from Public Health Scotland, where they have detected no cervical cancer cases in immunized women. And this is tremendous because it's moving towards cervical cancer in Scotland becoming eliminated. And on the right-hand side, the jurisdiction, Australia, which started HPV immunisation first and was straight on with immunising boys and girls simultaneously right from the start, they are heading towards a world first with cervical cancer elimination. So HPV immunisation is really key to reducing and essentially getting rid of cervical cancer. In addition, HPV protects against oropharyngeal cancers as well. However, a significant problem that we have is HPV uptake. And you can see, if you look in the left-hand box, in 22-23, in Leicester, the first dose uptake was just over 50% for girls. And when you look for boys, first dose uptake in that same time period was just 43%. So this is a real opportunity, and I'm working with public health colleagues to look at this and to see what we can do to expand this, because going forward, this has to be the way of improving our cervical cancer and also our oropharyngeal cancer um, out, incidence and outcomes. And on the right-hand side, you can see the same sort of information, but expressed as a graph with the two red arrows highlighting where we are in Leicester. In Leicestershire, the uptake is far greater and much more akin to the England average, if not a little bit higher. So when we're thinking about cervical screening, coming back to that, what can we do to improve uptake? And one of the things is, if we look on the right-hand side here, is that there is a deprivation gradient in terms of uptake. So the least deprived communities are more likely to take up cervical screening. And on the left-hand side is a really helpful report and set of ideas and resources all about how we can address inequalities in uptake of cervical screening. And if you go to that resource, there's a really helpful PDF document that will list all of the interventions that have been tried in different groups and what the outcomes were. And so that's worth clicking on, worth having if you want to have a project or do something within your neighbourhood, PCN or practice in terms of looking at raising cervical screening uptake. Now, Cancer Research UK in the left-hand box have actually got some really good resources around encouraging participation. But there is, in the middle box, an even more exciting element that's coming our way this year. And this is called self-sampling. And you may have heard of this, that women are sent a vaginal swab, which they do within their own home and then drop off at the practice. We send it in to UHL and they will test it, or the hub will test it for HPV. Now, this has been piloted in London and is readily available across Europe now. So we have reached a point where those women who decline screening will be offered that. This isn't at the moment being talked about as an option for all women, but I'm hoping that it will come. And for our older women, there's often worry and sometimes pain because of being postmenopausal, because between 50 and 64, the majority of women are either going through or have gone through menopause, and you have vaginal dryness and therefore the potential for pain. So what they found in the test studies around London was that actually older women really liked this as well as younger women, who found that they could do it without having to take time out to attend the surgery. And then on the right-hand side, a publication which was published in this last week's BMJ is around using menstrual blood and testing that for HPV. So they had a little pad which was returned and that was tested for HPV. And of course, that is research that's ongoing, needs to be replicated within our populations, but just to show that there is a lot of work going on and to keep your eyes open for these changes as they become relevant. Next, I'd like to move on to breast screening. And breast screening invites all women from the age of 50 to 70. And it's important to note that there is information about trans and non-binary women who were female at birth and so on. Really important information. It perhaps tracks back to how we code within our practices and whether we are aware of trans men who could be eligible. But women are invited between the ages of 50 and 70, and this is on a 3-yearly cycle. But it does mean that some women won't get it until they're 52 or 53, depending on where the cycle is in your area. I've highlighted at the bottom of that box if you are older than 70, and I'm going to show you a slide in a minute which explains why I've highlighted it. But it's really important that women realize that if they are well and don't have other overwhelming comorbidities, they can still have screening on a 3-yearly cycle, but they have to request this. And there's a straightforward route of contacting local breast screening unit, or you can contact the hub yourselves. And when we think about breast screening, there are in fact other groups of women that are going to have a wider range of screening. So for example, if you have a strong family history, or if you're a Jewish ancestry and you've been to a genetics service, they can decide whether you require screening at an earlier age. And for some conditions, like the BRCAs, you might consider having screening from the age of 40. And the reason why we screen from 50 and not starting at 40 or 45, which is what they do in America, is that mammograms aren't as sensitive when breast density is greater. And when you are younger, generally pre or perimenopausal, the density of the breast means that it's harder to detect abnormal areas. And I'll come back onto breast density in a minute. So with breast screening, what do we know? We know from 22, 23, and the latest data is going to be published at the end of the month. We know that over 2 million women had been screened, but that's a slight drop. And this is one of the things that's happening nationally, that we went from having an almost 68 to 70% uptake. Now it's gone down to 64.5%. So we're seeing a gradual drop in breast screening uptake, and we'll talk in a few minutes about things that can be done and why that might matter. But importantly, nearly 19,000 women had cancers detected through screening. And one of the debates that we have is breast cancer now has one of the highest survivals. In fact, it's the highest survival for 10 years of all cancers. And it's 85 to 90% survival. And partly it's through much better treatments, and partly it's through screening. And there is a set of data where people worry about screening picking up cancers that perhaps wouldn't have caused any specific problem. And you may have heard of ductal carcinoma in situ. That is a debate. But at the moment, the current recommendations from the National Screening Committee and the Department of Health is that breast screening is a programme that we're supporting and that does more good than harm. Coming back to why I mentioned the self notification for screening. So with the red arrows at the bottom of the graph, you can see I've highlighted from 50 to 70, those areas, those age centiles that are going to get screened. So between 50 and 74. But you can see that in the older age groups, you do actually still have significant risks of getting breast cancer. And if you are a woman that's otherwise well, there is a very good case to be made for continuing with breast cancer screening. And when you request the screening, you will get information explaining about your rights and the diagnostic rates and so on in the older age groups. But worth bearing in mind, and I, in practice, have had women who have had their early breast cancers detected 3 years after they were discharged from the program. And so it's worth thinking about. I did look into this around Leicester and Leicestershire, and in fact, in the outer areas of Leicestershire, and particularly in East Leicestershire, there are larger numbers of women who are referring themselves to continue screening, not so much in the city. Now, when it comes to breast screening, of course, that involves mammography, which is taking X-rays in 2 dimensions of the breast. And on the left-hand side, you can see something that was announced last year, but is now underway, which is a very large trial looking at using AI to report the mammograms. And that's a really important step because at the moment, the mammograms are read by 2 radiologists. This is a way of having AI read it and then have the results that it flags to be looked at by a radiologist and confirmed or retested. So that's a really important current project. We don't need to be aware of that, just to know that this is going on. On the right-hand side is something called the BRAID trial. And I mentioned breast density earlier on. What we are aware of is that when you go for a mammogram, some women will have more dense breast tissue than other women. And it's not possible to predict in any clinical way whether you are going to have dense breasts or not dense breasts. However, if you have dense breasts, what the epidemiological data tells us is that it's harder to pick out small cancers. And so there are a number of studies going on looking at whether those women with dense breasts who are picked up through mammography should have additional testing. In France, if you have dense breasts, then they undertake an ultrasound scan of the breast to see if there are any small lesions. In America, women are required to be told that they have dense breasts, and in some of their states, they also undertake MRI screening. In England, we are still looking to see what the best evidence is for how we can work with those women if they're found to have dense breasts. Importantly, the programme does not tell you if you have increased breast density. So as a woman attending the programme, you will just get the same result back to you, whether you have dense breasts or not. So that's something perhaps to reflect upon. I have taken this up with the experts, and because I didn't feel particularly happy about that, and I thought surely that's patient information that you should be sharing. But we had a long discussion about this, and when I've looked at the data around what other countries are doing, it does turn out that there isn't actually one clear route ahead. And what's being done with trying to build up an evidence base for our UK population feels reasonable at this stage. But I'm hoping that out of the research will come change. In order to improve breast screening uptake, and I am really aware that this doesn't form part of our contractual obligation, but if you did want to, if you did want to connect with your ladies that declined breast screening and you wanted to encourage them to do so, the pink video on the left was made by Kelly Lambert, who's our breast cancer lead at Glenfield, and it takes the woman through the screening journey, shows them what the mammogram is. You get to see the staff who undertake it. You see that that it's all women staff and so on. On the right-hand side is a London-based resource, which is in multiple languages and is animated. And it might be worth looking at that and seeing if that can help your population. We do have a Hindi version of the NHS breast screening video, but I haven't put the link on here. If you are interested or you want to think about Gujarati-based versions, we have an AI resource now within the Cancer Alliance where we can create videos in multiple languages. So if that is something that interests you, just email me and we can have a chat. Let's move on now to bowel screening. And that's what the bowel screening looks like. Slightly out of focus at the moment. I'm not sure why. But for those of us that have had the pleasure either of doing bowel cancer screening or having to complete a FIT test for symptoms, this is what the kit looks like. I've put underneath a telephone number, and the telephone number is the number that your patients can ring if they've lost the kit, damaged the kit, if the dog ate it, or if, having had a chat with you, they decide that they want to have a kit. They ring that 0800 number, then they can request another kit to be sent out to them. And when we think about bowel screening, something really important is happening this year. So this is a summary across the home nations, but we're just going to look at England. So this year, patients are being invited every 2 years from the age of 50 all the way up to 74. So that's going to be 2 years. And then once you've reached 75, just like with breast screening, you can carry on. And in your very last bowel screen, they mention it in a small paragraph at the end of the letter. But this is something that if you are well, you might want to carry on doing. And that reflects that the peak age of incidence of bowel cancer is actually in the upper 70s. So this is obviously a decision that's made with informed consent by the patient. But if they want to do that, they can request the kit telephoning that number every 2 years. If you look down where I've written threshold, and that is a key change this year. At the moment, when you complete the kit, if your FIT level is greater than 120 micrograms per gram, that's classified as positive and you're invited to have a colonoscopy. However, this year, England is going to come in line with Scotland and Wales and reduce that positivity threshold down to 80. And that, when we look at the pilot data from Derbyshire, that is likely to pick up 30% more early cancers, 20% more early polyps. It's essentially a really good thing. And that is going to be coming our way soon. Because we're GPs, an important thing that we need to be mindful of is the difference between the symptomatic pathway when we request a FIT test, when you offer a FIT kit or your reception staff offer a FIT kit to the patients versus a screening FIT kit. The key thing here is that you can have a screening FIT that's normal because the cutoff for that is currently 120. So if you have a patient with symptoms, but their screening kit 3 months ago was normal, you should be requesting a symptomatic FIT because our FIT triggers at 10. So greater than 10, we should be thinking about referral into the lower GI pathway. And this is a very useful reminder for yourselves, for trainees, for anyone that requests FIT tests about this. Because every now and again, our patients will be fooled into not presenting because they feel, well, I've had the bowel screening tests and everything's fine, so I could ignore the bleeding or I can ignore the pain or the funny lump I can feel. We must be aware of that difference between screening and symptomatic. The other thing with bowel screening that's, again, really useful and not many of us are aware of is that if you have visual impairment, you can imagine how difficult it could be to do the sample. But there is a device that's been produced, and if you are coding your patients as being blind or partially sighted, then they can have this special fit aid. And you may want to, as a project for yourselves or for trainees, or just as a general QI project, just confirm that your patients between 50 and 74 who are registered partially sighted, well, can we let the bowel screening hub know, and they can send this different kit, which has got braille instruction options, an audio and audio or video instructions as well. This was designed with blind people and has gone down really well with that particular cohort. So to get that, you just ring the telephone number or contact the hub in Nottingham. I wanted to come back now just to think about the cancer screening. And when we look at the performance overall, I just wanted to highlight a couple of things, which is the ethnicity and deprivation elements of where we are working. So these graphs, and if you go to the bottom left graph, which is the bowel screening coverage, if you look at the percentage mixed ethnicity here, it's expressed as percentage Black and Asian by PCN, then you can see the gradient that as we get greater numbers of mixed ethnicity, you do get lower take up. And this applies across the board with breast screening and cervical screening with both age groups. So that's ethnicity. But of course, this also applies to deprivation. And that bottom left is again the bowel cancer screen and showing you that if you have a more deprived population, the likelihood is that you will have a lower uptake based on the routine invitation process. So then we're into why aren't people participating? And I'm going back to the cancer awareness measure that I mentioned a few slides ago. And so we have the particular fears and concerns. When we think about bowel screening, we have specific issues around people finding it messy to complete or embarrassing or frightened of what it might show. And so these are particular elements that put people off. And so that means that if we're going to do something, if we're going to offer people information or send them a letter, then if we're able to address those concerns, then perhaps, or mitigate those concerns, then perhaps that will encourage people to take up the bowel screen. And when we think about breast screening, there are a number of areas that would improve breast screening uptake, and we've shared this with our breast screening colleagues. But interestingly, a lot of women do feel that if they had symptoms of breast cancer, they'd be more likely to attend. So there's something about the messaging and recognizing that actually this is meant for women who don't have symptoms. The key thing, though, was having a bit of choice around when you have it done. And lots of women were concerned that it wasn't available consistently at weekends or in evenings. So there's a structural element here as well. So the information has been produced for ourselves as a geography in LLR around the things that can be done. We are going through a phase of reorganization, as I'm certain that you know. And so how many of these things we might be in a position to address going forward remains to be seen. But when it comes to bowel screening, this is one of the areas where I have done some work. And this, if you click on this image, you go through to the LLR ICB bowel screening pilot project that we ran in Spinney Hill practice. And what we did was for those men and women who were invited between the ages, when we started, it was 54, between 54 and 74. If it was their first time, we sent the video out just to show them. And the video was also available in Gujarati and in Hindi. So you can choose which version to send out to your patients. And so we tried this out, and what we found on our small pilot was that actually those people that were between 50 and 50, sorry, between 54 and 60 were more likely to respond to this than the over 60s. And that perhaps reflects a familiarity with watching the video on your smartphone, perhaps something to do with having the information given to you in a language that you could understand. So this was a small pilot. If you want to use the videos, again, if you want to try and improve uptake, that's something that is already available. Now, when it comes to improving bowel screening uptake, there's a Cancer Research UK resource here, but the game changer has actually also just been developed, which is a special tool from Cancer Research UK, looking at all the evidence-based interventions that will improve your bowel screening uptake. And you can download this tool and you can search it by looking to see which interventions help men, help ethnic minority groups, help in urban settings or suburban settings. So you can filter through this grid. And one of the things that I've done is, having used this grid to look at uptake data, I've connected with an organisation in Lancashire that's had really good results with a large minority population black men. And so we've talked about how we can learn from what they've done and how that could be applied in the East Midlands. So again, this is something that if you want to look at improving uptake, you can do that. You can also get your own screening data. And I've taken, just as an example, 2 constituencies in Leicester City, Leicester West and Leicester South. And you can see here that the uptake rates for both of those are a little bit lower than the national average. And so, those are areas, and you can, by clicking on these boxes, go through, look at your constituency and see what the uptake rate is. But then if you wanted to go down a little bit deeper into your own practice, I've taken, just as an example, Leicester City South PCN, and I've just shown you within the PCN, you can see the bowel screening uptake within each of the practices, so that you can see how each practice is doing. And it may be that looking and appreciating your own data stimulates you to think about how we could improve it. And then you can go back to that tool around how to improve screening uptake within different populations. If you click on this, you go through to a really helpful tool produced by Public Health called Fingertips, and you can look at this and lots of your cancer data. Now, I'm going to mention, and I will talk about this a little bit more next time, Melanie Davis is a professor here in Leicester, and she works with Kamlesh Kunti and Azhar Faruqi in the Diabetes Centre. And her team wrote 3 years ago that cancer is now the leading cause of death in diabetes, and that, in fact, early cancer detection could reduce the number of avoidable cancer deaths in diabetes. And in the right-hand box, I've put in a particular action from the cancer plan, which was released last week on the 4th of February. And one of the actions that they have started to look at is, can we incorporate cancer checks into touchpoints like chronic disease reviews? And I've been running a project in Derbyshire which does exactly that. And if people are interested, I can talk to you about how we're thinking about doing it, and how actually I've already modified the National Ardens template as well as the LHIS diabetes template to allow us to record that prompting and so on. So I'll come back to that if people are interested. Now, the final thing that I'm going to share with you, and I mentioned this earlier on, is know your number. So quick show of hands, who's over 50, who's eligible to do the bowel screening test? Excellent. one person's bold enough to say, right, guys, I've done the bowel screening test a few times now. And when you get the result back, it just says, well done, nothing to see here. If you have these symptoms, and we'll send you another kit in 2 years' time. Okay. However, I've told you that the bowel screening kit cuts off at 120. So if your FITS level was actually 118, would you want to know? Would you want your GP to perhaps think about doing a full blood count and ferritin? Would you? And if you were to do that, how could it be done? Right. The first thing, Darren, and others, they don't tell you. Okay, there is nothing on the website, nothing in the letters that come to you. But under freedom of information, if you look back at the letter, then what you do is you can email the hub with your NHS number, date of birth, and the date that you did the test and say, excuse me, could you tell me what my actual number is? And they're obliged to tell you. Now, when they tell you, you get it back as, when I did it, and I did this last month, it comes back as, okay, it was less than 6. And I say, brilliant, nothing to worry about. If it had come back higher, and the reason why I'm asking is because I want to know. Because if it is higher, then I'm balancing the needs of the screening program. The screening program is trying to decide for the whole population of England how much colonoscopy capacity there is. But as an individual, I think I can make a choice. So guys, for those of you that are over 50, think about whether you would want to know. And I can't tell you to do things one way or another. I can only offer you that choice. And you can think that. The way that you email the hub, if you've had the letter, then that should have an email address on it. Yep, on the top right, it's got the email and it says, please ensure you quote your full name, NHS number, and date of birth for all correspondence. So it's the Nottingham Screening Hub. So you can look it up there. If you get stuck with any of this, just ring that 0800 number and they will tell you how to do it. Now, I can tell you that in the screening hubs, every year, they have about 12 people who ring them. So that tells you that very few people actually know about this and do this. And the only other person that I've met in the last couple of years was the National Cancer Director who knew about it and did it for himself. So this is something that they don't tell you, but if you wanted to know, you can do. And for those of us who are lucky enough not to be over 50, but have parents who are over 50, perhaps you might want to reflect on whether this could be relevant to share with your parents. And also, I don't know about you, but my parents don't always listen to me when it comes to medical things. But if you want, you can always say, look, I was on a cancer training and somebody mentioned this, etc. So, I see it as being informed choice. And if you want to do that, then please remember that there is a route to do it. If you get stuck with it or you want to run it past me again, because I've got a real bee in my bonnet about it. I've actually got some data as well that shows you why it works. The key thing to remember is that at a cutoff of 120, the program is set up to detect less than half of the cancers in that group. So that's something that they don't tell you either. Now, I can see in the chat that there is a question about PSA. And if it's all right, Alizadeh, what I will do is answer that next time when we're talking about cancer diagnostics. So if that's okay. And yeah, so a couple of questions. One from Darren about, is the colonoscopy service set up to cope with the reduced thresholds? It will be. And we will only switch on that fit at 80 once the colonoscopy capacity is there. Um, with the HPV vaccination, there are very particular rules about giving it. And we as GPs can offer catch-up vaccinations for which we get funded. Those boys in their 20s, unfortunately, if you're, there is a cut-off date. Now, I've got a feeling it's 24, but I'd have to look at the actual hub. You can get all that information there. Okay, so I think if I stop there, because we've hit 1 o'clock, and if, right, okay,
Yeah,
over to you,
Pawan.
Adam.
Yeah, no, lovely. Thank you so much. Yeah, and I was very mindful of the time. Appreciate we're just slightly running over. Amazing as always, Pawan. So thorough and lots to kind of digest and reflect on. I know you've answered some of the questions already in the chat. So Asma's comment about the HPV vaccine. Parastu did make a comment about with the cervical cancer screening. I'm sure I could help. Need better communication of this. How it is communicated is important. So maybe Parastu, if you email Pawan.
Yeah.
Yeah, and then
Um,
have a discussion about that.
Absolutely. Adam, I've
Um,
been involved in multiple projects like that, so I've got a fair bit of experience and very happy to help.
yeah. And you've answered Darren's question about the colonoscopy service. And yeah, I suppose it was just the questions there about the actual evidence for screening programs reducing disease mortality rather
Yep.
than early diagnosis bias. It's a good question.
And that's such an important thing. And that data is taken into account by the National Screening Committee. And we do have GPs on that committee as well as statisticians and so on. This is why PSA isn't a program. And the particular program that does cause difficulty is breast because of ductal carcinoma in situ and how you get different types of DCIS. And there are some countries where there's been big debates. For example, in Switzerland, there was a big debate about whether to switch off screening and just really emphasize self-examination. So that is a key debate, one that's been looked at by Cochrane. They sort of come down equivocally. And, it's at the moment we have to be guided by what the national team has decided is appropriate. That's not to say that it can't be improved, and things like the breast density has got to be a big improvement once they decide what the additional tests should be. And also, one of the elements I feel concerned about, if as a woman I had dense breasts but didn't know about it, well, actually, perhaps I could be encouraged to self-examine. So that there are opportunities that I think the screening programs could utilize but aren't yet.
Thank you, Pawan. I think what we'll do, if there's any other remaining questions, we'll probably discuss them next time if that's okay, because obviously just very mindful of the time for people. But once again, thank you so much, Pawan. Really appreciate that. I'd like to thank you all for attending as well and kind of giving your great questions and comments as always. Really appreciate that. For those of you who missed it at the start, if you've registered, you will be automatically sent the recording and we will be sending out the slides as well. For those of you who haven't, on our website where our CPD calendar is, we will be uploading the copy of the recording on there as well, so you can watch that on demand. Otherwise, I hope you all have a good rest of the afternoon and a weekend. And I look forward to seeing you in 2 weeks' time for our final part in our 3-part series on cancer education with Pawan. So thank you all. Take care.